Good morning. Today we are here to understand the basics of fractures, which will help you to understand the management of fractures. So you have to be very attentive because it is the basics of orthopedics. And once you understand this basic issue of fracture, you would be able to answer the questions well and treat the patients well when the need arises. Why is the slide not moving? I hope you can see the slide. Yeah. So how do we define a fracture? Fracture is a break or breach in the continuity of bone. That means anywhere in the cortex, if you find on X-ray that there is a breach or a break, then you are supposed to call it a fracture. If the skin overlying a fracture is complete, uninjured, intact, then that fracture is called as a closed fracture or a simple fracture. While the skin over the fracture, if it is breached, if it is also injured, and you can see some blood outside, or you assume that the fracture is communicating with the exterior, in that case, that fracture has to be called as an open or a compound fracture. Just a minute, just me check. Yeah. Now, let me see what you have understood. Have you understood something or not? This is X-ray. Who will answer what X-ray is this? Who will comment on the X-ray? I'll tell you how to comment on X-ray. First of all, you see the X-ray and you decide this X-ray is of a child or an adult. How would you say that? Once you know that the epiphyses are unfused, there is still epiphyseal plate visible on the X-ray, you must call it a X-ray of a developing human skeleton, that is a child whose epiphyseal plate is still unfused. So in this case, you can clearly see that you cannot see any epiphyseal plate and all the epiphyses have been fused with the diaphyses. Hence, this is an X-ray of a skeletally mature human being. Secondly, you have to comment which part of the body this X-ray belongs to. And it is an X-ray of lower part of humerus, elbow joint, and upper parts of ulna and radius. Then you have to comment which view of the X-ray it is. And you can clearly say that this is an X-ray of AP view, anterior-posterior view. And at last, you have to comment on any abnormality seen. So now if we have to comment on the X-ray, this is an X-ray of a skeletally mature person showing lower end of arm, humerus, elbow, upper end of ulna and radius. And there is some abnormalities which could be, now I'm asking you, is it a simple fracture, A, or it is B, a compound fracture, or it is C, a dislocation, or it is D, a subluxation? Who will tell me it is A, B, C, D? Yeah. So, interestingly, all of you are wrong. Why you are wrong? It is not a simple fracture because you cannot see the skin, condition of the skin. You don't know whether it is broken or unbroken. It is not a compound fracture because again you cannot see the skin. You don't know whether the skin is injured or not. It is not a dislocation. It is a case of fracture. The joints are intact and neither it is a subluxation. Since the joint is intact, so it is neither A, B, C, D. It is something else. It is this question has been framed to make you think what is right, what is wrong. So the right answer does not reflect in the list of answers. Now, once you know what is a compound fracture, again, what is a compound fracture? Compound fracture is when the skin overlying the fracture is broken and the fracture communicates with the exterior. You can see blood. You can see the tissue inside. That is a compound fracture. Gustilo Anderson has done a great job by classifying compound fractures. How do we classify it? Gustilo Anderson type 1 is a compound fracture which has a wound on the skin, the size of which is less than 1 centimeter. The wound is so small, even the puncture wound. Sometimes what happens? The sharp spicule of the bone, fractured fragment bone, the sharp spicule comes out of the skin, again goes back into the wound, causing a small puncture wound on the skin, through which some blood may come out, may not come out. But you can see from the top there is a small hole over the fracture site, and this hole makes the fracture to be qualified as number 1, compound fracture, and number 2, since the size of the hole is so small, it is less than 1 centimeter, you call it Gustilo-Anderson type 1. What is Gustilo-Anderson type 2? Gustilo-Anderson type 2 is a bit more severe injury. The wound is much bigger. It is anything bigger than 1 centimeter. There is moderate soft tissue injury. And the key to diagnose is, number 1, the wound is bigger than 1 centimeter. Number 2, the periosteum of the bone is intact. Hope you know what is periosteum. Do you know what is periosteum? Yes. Periosteum is the outer layer which covers the bone and helps in new bone formation. That is periosteum. So Gustilo-Anderson type 2 is, number 1, wound is bigger than 1 centimeter. Number 2, periosteum is intact. And number 3, there is moderate soft tissue injury. Gustilo-Anderson type 3. Type 3 can be A, B, C. Now let's see what is A. Wound, again the wound is bigger than 1 centimeter. Here the soft tissue damage is severe. Periosteum is peeled off, but there is adequate soft tissue coverage over the fracture. That means skin is gone, wound is bigger than 1 centimeter, periosteum is Periosteum is quite big. Periosteum is avulsed here. But the catch is, although there is severe soft tissue injury, although periosteum is avulsed, but the catch of 3A is that the fracture is covered by soft tissue. There is adequate soft tissue coverage over the fracture. That means bones are not exposed, right? 3A, wound more than 1 centimeter, severe soft tissue injury, and so it was type 3A. What do you understand by type 3B? Of course, the wound is big. There is a severe soft tissue injury. Periosteum stripping is present like all type 3, right? But the catch here is what makes it B, not A, that there is not enough soft tissue coverage over the fracture site. Can you see in the X-ray? Can you see in the picture that the bones are exposed? There is no adequate soft tissue coverage. So, Gustilo Anderson, GA type 3B is fracture, breach in the continuity of bone, compound fracture, there is a wound over the fracture site. Type 3, because the periosteum is damaged, severe soft tissue injury, and type 3B, because there is not adequate soft tissue coverage over the fracture site. Lastly, there is GA type 3C. Any wound size should be compound, but there has to be a vascular injury. If there is a vascular injury, you have to vascular means big major arterial vessel injury. Small capillaries are always injured, but they don't make it type 3C. To qualify a fracture to be a type 3C, you have to have a vascular injury along with the fracture site, along with the fracture and compounding. So let's go up and again go back. GA1 wound is less than 1 centimeter. GA2 wound is bigger than 1 centimeter. Soft tissue injury is moderate and the periosteum is intact. GA type 3 is wound is bigger than 1 cm. Soft tissue injury is severe. Periosteum is peeled off. But in A, there is adequate soft tissue coverage. In 3B, there is not adequate soft tissue coverage, rest being the same. And in type C, there is a vascular injury. Whatever the size of the wound, even if there is a puncture wound and if any major artery is injured, it is type 3C. Now, after understanding the basics of fracture, let us try to know what is a dislocation and what is a subluxation. In the photograph, you can see this is a photo of a hip joint. On one side, there is a socket, and on the other side, there is head of femur. Socket is made by acetabulum, and the ball is made by the head of femur. So this ball and cup, this ball and socket makes this ball and socket joint, and this is a hip joint. In the first picture, you can very clearly see that the head of the femur is well contained in the cup, in the socket. Head is fully contained in the socket. In the second picture, you can see that ball is trying to move out of the socket, but still it is in contact with the socket. While dislocation shows that the ball has totally moved out of the acetabulum. Ball has totally moved out of the acetabulum and there is no contact. So now we'll see what is dislocation and what is a subluxation. So dislocation. Dislocation is when the articulating surfaces are not in total contact anymore. What is what is an articular surface? The surface of the bone which forms the joint. Like in this case, whole head of the femur is an articular surface. Whole acetabulum is an articular surface because this is the surface which is in contact of the opposite side of the bone to form a joint, right? So when the articulating surfaces are not in total contact, it is dislocation. What is subluxation? When the articular surfaces are partially in contact. Can you see? In the lower, in the third diagram, in the second diagram, the bone of the half of the bone of the head is still in contact with the acetabulum. So partially out. Subluxation, totally out is dislocation. Now let us see this. It is a case of, no. Let me check. Who can comment on the X-ray properly? How many of you would like to answer this question? Comment on the X-ray, please. Yes, you. Good. So this is an X-ray of a undeveloped skeleton. Why? Because you can see the epiphyseal plate and fused epiphyses are still there. So in the presence of unfused epiphyses, you have to label it as a X-ray of a child, X-ray of a growing skeleton. What do you see in the X-ray? Now I want you to answer. Is it A, undisplaced fracture? It is B, subluxation. It is D, or it is C, dislocation, or it is D, none of the above. Who will answer it? Who will answer my question? So now you see uh, this interesting X-ray is showing there is some abnormality. So is it an undisplaced fracture? No. Is it a fracture? Yes, you can see a breach in the continuity of bone. That means there is a fracture. This is for sure. But is it an undisplaced fracture? No, it is not an undisplaced fracture. You can very well see that the fracture fragments are pretty displaced, and rather there is overriding of the fragments. Is it B, subluxation? No, the joint is not involved. It is a clear case of fracture. Is it dislocation? No, again, the joint is not involved. It's a clear case of fracture. So the correct answer is D. It is none of the above. So that means you have to really look upon the finer aspects of the X-ray and just not hastily comment on the X-ray. Now, one of the basic things which you all must know is how to describe a displacement. Whenever you have to describe displacement, like when there is a fracture, the fracture fragments don't stay in its place. They always move. Some can move in any direction depending on the force, on the impact. The you can see in the X-rays, it is a plain X-ray of a child since the epiphyses are unfused, and it is X-ray of the femur, AP and lateral views, showing there is a fracture of shaft femur. So the you can see upper fragment is proximal fragment, and farther fragment is called as distal fragment. So it is a rule that the fracture away from the fracture line is called as the distal fracture. So now how will you describe the displacement? You describe the displacement of fragments based on the position of the distal fragment. Like in this case, you can clearly see that the distal fragment has gone laterally and dorsally. So the displacement in this fracture is lateral and dorsal because the distal fragment has moved so, right? There can be some cases where you find a combination. A combination of what? A combination of fracture and dislocation. That means there is a breach in the continuity of bone as well as articular surfaces are no longer in contact. Such a combination is called as fracture dislocation combination, which is very common in hip joint. Like in the first case, you find there is a there are three pictures on the screen, 1, 2, 3. All the pictures shows, number one, there is a fracture of the femur head, and all these pictures show that there is also dislocation. That means the femur head has moved out of the sternum. So it is a combination of fracture, dislocation. It can be type A, type B, type uh, um, 1A, type 1B, 2B. One A is when the fracture is very small. One B when the fracture is little bigger, and 1,3C when there is a fracture of the head transversely. It is these three are the various types of fracture dislocations. If you really examine the fracture pattern, you can clearly arrive at the diagnosis of the mechanism of the fracture. How did the fracture occur? Fracture can be due to direct violence causing the fracture at the site of impact of force, Or fracture can also be due to indirect violence. Force is transmitted to a bone away from the site of impact, producing a fracture there. And based on this different two mechanism, we can also classify fractures. It can be direct injury. Example, direct blow causing a transverse fracture. B, crushing injury. This causes comminuted fracture with gross soft tissue injury. So what do you understand by comminuted fracture? When there are multiple fractures lying at the same spot is comminuted fracture. These two are the examples, these two are the causes of examples of direct injury. What are the examples of indirect injury? Number one, compression injury. When there is compression, this can cause short oblique fracture, or there can be twisting injury. This can cause spiral fracture, or there can be bending injury. In the bending injury, you always find a triangular fragment, and there can be tension injury. When both the fragments are pulled apart, this causes a transverse fracture, or there is a eversion at the site of tendon or ligament. We can also classify fractures depending upon the deformity. The fracture can be undisplaced fracture. The fracture ends are in anatomical position aligned with each other. Or the fragments can be displaced fracture. The fracture ends are far apart from each other, widely displaced from each other. One more interesting way to classify a fracture is classification based on the pattern of fracture lines. Is the fracture line transverse? So it can be transverse fracture. The fracture lines run at a right angle or less than 30 degrees of obliquity to the long axis of bone. There is a long axis. The fracture is either at 90 degree or less than 30 degree. In the oblique fracture, the fracture line runs with the angle of more than 30 degree with the obliquity, with the long axis. So if the angle is more than 30 degree, if the fracture line makes an angle of more than 30 degree with the long axis of the bone, then that is an oblique fracture. What is a spiral fracture? Due to turning and twisting force, the fracture line curves around a bone in a spiral manner. And lastly, there is comminuted fracture, when there are more than two fracture fragments. When there are more than two fracture fragments, you call it a comminuted fracture. So these are the various pictures to help you understand what are the various types of fractures. In the first, you can see a transverse fracture. In the second, you can see a linear fracture. In the third, you can see oblique fracture. That means the fracture line makes an angle more than 30 degrees with the long axis of the bone, but it is non-displaced. In the fourth picture, it is oblique, but it is displaced. In the fifth picture, there is spiral fracture, twisting injury. There is one more interesting fracture, that is green stick fracture, where in the child, what happens sometimes due to thick periosteum, only one side of the cortex is broken and the other side is intact. So this fracture is called as green stick fracture. And then lastly, when there are multiple fracture fragments or the fracture there are multiple fracture lines at the same spot. You call it a comminuted fracture. Apart from these, there can be various other fractures. It can be impacted fracture. When one fracture fragment is driven over the other fracture fragment, examples can be neck femur, neck humerus, Cody's fracture. Or it can be compression fracture, where compression fractures over a thin bone. When the bone is compressed by trauma, this also is very common in vertebral fracture or calcaneal. There are two fractures which show compression fractures. Number one is in vertebra. Number two is in calcaneum. There can be a very interesting fracture, which is called as avulsion fracture. Occurs when there is sudden contraction of muscles or ligaments in which a portion of the bone attached gets pulled off, and the examples are fracture of the upper pole of patella due to pull of quadriceps femur, fracture of the base of fifth metatarsal. This is an avulsion fracture. This is called as Jones fracture also, and it is due to the pull of peroneus brevis muscle. This fracture is very commonly seen in sprain. When while walking, you suddenly fell down due to inward twisting of your ankle joint, inversion injury. This is called as sprain, commonly seen in girls that are wearing high heels or carelessly walking on the stairs, usually busy on the mobile phone. They fell down, their ankle gets twisted, there's pain on the outside of the ankle, and there can be a fracture, which is the fracture of the base of the fifth metatarsal, called as Jones fracture. This fracture is also a avulsion fracture. So these are the various depiction showing impacted fracture, where the fracture fragments are driven into each other. Calcaneal avulsion fracture, where due to sudden contraction of the gastrocnemius, the part of the calcaneum on which the tendo-achilles is inserted can get avulsed, fractured. This is also calcaneal avulsion fracture. And the last picture on the screen is compression fracture, where usually in osteoporosis or in sudden fall from height, there is a fracture in the vertebrae. It can also be seen in old age. Old age is due to osteoporosis. This is a compression fracture. Green stick fractures are usually seen in young bones, bones of children, where the bones are weak, but the periosteum is strong. Here the fracture is incomplete. Why it is important to differentiate identify a green stick fracture? It is important because if you don't identify it, you will miss it. And if you miss it, you just apply a plaster and the patient will come to you with a deformity, because since it's an incomplete fracture, new bone will only form at the fracture site and overgrow than the opposite side, which is normal. So when you get a green stick fracture, you have to make this incomplete fracture into a complete fracture, so that new bone forms all around and there is equal new bone formation and growth of the bone. What is a birth injury? Birth fracture. At times when there is a difficult labor during birth, when the fetus is in very abnormal position, and when during recovery of a child, of a baby, due to sudden jerk or pull or heavy pull, the thin, slender bones of the fetus of the baby can get fractured. So, fracture of the newborn baby due to injury during delivery is called as a birth fracture. What is a depressed fracture? Depressed fracture is usually seen in skull, where a part of the bone gets depressed. In the case of skull, it would get depressed in the brain. Again, in the skull, you find one more fracture that is called a stellate fracture. This occurs in flat bones of the skull and in patella, where fracture line runs into various directions from the same spot. Either it is seen in patella or it is seen in the skull. So very clear, very beautiful pictures. You can see a depressed fracture of the skull in the first case. In the middle, you can see a stellate fracture in the patella. And in the third picture, you can see a green stick fracture. A pathological fracture is very important, which is my favorite topic. Here you get a patient who has got a fracture, clearly shown on the X-ray. But you find that the history of trauma is very trivial, very minimal trauma causing fracture. Then that should raise a suspicion in your minds that whether it is a pathological fracture. That means this fracture has occurred not in a normal bone. This fracture has occurred in a bone which has already been weakened by some disease process. That disease can be tumors, that disease can be osteoporosis, that disease can be rickets, osteogenesis imperfecta, that can be Paget's disease of bone, that can be hyperparathyroidism, that can be brown tumor, that can be fibrous dysplasia, radiation-induced fractures. All these things are a short list of the commonly seen pathological conditions existing in the bone where you might find a pathological fracture. Why it is not moving? Let's see. Yes. What is a stress fracture? This is not same as a pathological fracture. Stress fracture means these fractures usually occur in weight-bearing bones due to minimal but repeated stress. Bones which bear weight, if they are put to repeated minor stress due to overuse, those bones, even if they are strong, they can show minor fractures. These fractures are called as stress fractures. And the most common sites are second metatarsal of foot, called as march fracture. It can be upper tibia and fibula. It can be neck femur. It can be shaft of humerus in young cricketers, or in pubic rami, which is commonly seen in osteomalacia. You can see this stress fracture in the picture. This is a picture of a foot AP view, and you can find there's a fracture line going on the neck of shaft and neck of the second metatarsal. This fracture, where there is no history of major trauma, but there is history of repeated minor trauma, this fracture is called as stress fracture. So now just tell me, how do you diagnose a fracture? Very easy. The patient will complain of pain. There can be tenderness. There may be deformity. There may be inability to bear weight along with a recent history of trauma. When you will examine the patient, you'll find crepitus. This crepitus would be usually painful. There can be abnormal mobility of the bone fragments. There can be limb length discrepancy. That means fractured limb will show shorter, usually, length than the opposite limb. And you can also find swelling around the painful spot. Then you will advise specific radiological views that will confirm the diagnosis, and it will also show the displacement of the fracture fragments so as to decide upon the correct diagnosis treatment. Once you have diagnosed, and let me tell you what are the usual views of X-ray that we take. What are the usual views? The usual views that we take are AP view and lateral view, except in the case of hand and foot where you take AP and oblique views, because in the lateral views you find that all the bones are overlapping. So you cannot differentiate each metacarpal or phalanx. So you have to advise oblique views. And there are two more joints where you cannot advise AP and lateral views. Who will tell me? The three spots. In the chest, you have to advise AP view to detect fractures of the ribs, but you advise PA view when you have to see the lung and heart markings. There are two joints where you cannot identify the. So yes, as I was saying, there are two more joints where you cannot advise lateral views. One is hip joint. There you might have a problem. You may advise lateral view, but you have to advise the technician to know how to take a lateral view of the hip joint. But the one of the joint where you cannot take a lateral view, you have to take an axillary view, and that is a shoulder joint. Apart from X-rays, in the case of fracture, you at times have to advise CT scan. Now, what is an indication of a CT scan? CT scan is very useful in the cases of fractures in and around a joint. Joint is a 3D structure, complex structure. And just if you take AP lateral views, you might not know the exact configuration of the fracture fragment, and you might not know the various fracture lines. Usually there are many. If you don't have access to CT scan, you are supposed to take oblique views. So you take AP lateral and left and right oblique views to know more about the fracture around the joint. But if you have access to CT scan, you must take the help of CT scan. So now, after you have diagnosed the fractures and the fracture pattern, what you should do, what you need to do is manage the fractures. How would you manage? Very simple. By knowing the basics. And the basics are, number one, the aim of the fracture management is to restore the limb limb functionally and anatomically so that it is indistinguishable from the normal and the general principles of management are. So what is the basic aim of fracture management? That you have to restore the limb anatomically and functionally so that both the limbs are indistinguishable. Later, no one can say that this limb had fracture. What are the general principles of fracture management? Number one is first aid and resuscitation. You have to be smart at giving first aid. You have to do a basic job and you have to resuscitate. After giving the first aid and resuscitating, what you need to do is you have to safely transport the patient from the spot of accident or fall where the fracture has occurred. From that spot, the patient has to be transported to the hospital where you want. So the transport should be safe. So you have to take adequate precautions during transport so that no untoward injury happens. Third is assessment of the general condition, vitals for shock, addressing head and abdominal injury on priority basis. General condition has to, you cannot be focused on a limb or a fracture. You have to treat the whole patient and you have to really uh, assess like a plain MBBS, like an intern, the general condition of the fracture on a priority basis. On the priority basis are two organs, head and abdomen. These two head injuries cannot be left undiagnosed and similarly abdominal injuries cannot be ignored. So these two injuries have to be taken care of. Fourthly, you have to do an assessment of the general condition of limb for neurovascular involvement, ligament and tendon injuries. Many injuries end up in injuries to vessels or nerves or ligaments or tendons. Unless you know them by examining, how would you manage? And lastly, you have to perform all the radiological assessment options. After you have assessed the general condition, the limbs, the vascularity, everything, you have to reduce the fracture. Reduction of the fracture means realigning the fracture fragments into normal alignment. That is called as reduction. And this reduction can be of two types: closed reduction or open reduction. Closed reduction means when you, without opening the limb, just by superficial manipulation, you are able to move both the all the fracture fragments into its normal position. That is reduction by closed methods, or it can be open reduction. That means when you have to cut the skin so that you can control the fracture fragments and hold them and bring them into normal alignment. That is called as open reduction. So after you have reduced the fracture fragments, you have to immobilize the fracture fragments. Why? Because unless you immobilize, it won't heal. So how long will you keep it? As long as it heals. So as long as the bones are not healed, you have to apply something so that the fracture fragments are immobilized. And this can be either done conservatively or operatively. Conservatively means usually a plaster, and operatively means you have to put in some implants to hold the fracture fragments into its normal place until it heals. After the fracture fragment has healed, what do you do? You find that the fracture has healed, but the joints have become stiff. Now you have to mobilize the joint. And how would you mobilize the joint? Exercises. And that exercise program is best done by a physiotherapist. So you need a physiotherapist, a good one, to help regain the muscle strength and avoid the joint being stiff. So now after you have reduced the fracture fragments, our main job is to maintain the reduction. And how would you do that? You have two options. Either it can be conservative. You can go by plaster immobilization. You apply POP over the joint limb, or you can do a strapping. That can be buddy strapping or Jones strapping for AC joint, or sorry, clavicle strapping. Or the third option at times is functional cast bracing. It's a method of immobilization which permits the functioning of joints and the muscles while immobilizing the fracture. Functional cast bracing is a very good technique because usually what happens when you apply plaster, later the joint becomes stiff and the muscles become atrophied. There are many complications that can occur, which are called as plaster disease. So to avoid plaster disease, one of the options is to apply a functional cast brace in which you allow the joint to move and mm, the patient move the joint uh, so that the joint does not become stiff and the muscles continue to have their normal strength. This slide is again not working. I am just working on it. Yes. So as I was telling you, what are the disadvantages of a conservative method? Number one, the joints can become stiff. Number two, there can be wasting of muscles. Number three, there can be loss of reduction. See, when you apply a plaster or you do a strapping, you really cannot properly control the fracture fragments and there can be loss of reduction. Fracture can move. And moreover, how much good you may try, sometimes the fracture pattern is so, can be spiral, belong obliques, that even after all your attempts, you might not be able to perfectly anatomically align the fracture fragments in the best possible way. That might not be possible. And the third is pressure sore. Sometimes fracture happens and you apply a plaster, and when you open the plaster you find that the fracture has end up in a fracture sore. So the patient can show pressure sores. Very interesting. These are the problems which make us think, do we have some other option other than conservative method? And then you arrive at a option which is a surgical management of fractures. These are the present methods of choice for displaced fracture management, and these allows us to follow the principles of OYO fracture management, which are: number one, you are able to get a perfect anatomical reduction. Number two, you get a rigid fixation of fracture fragments; they don't move. And number three, with these two in place, early range of motions of joints are allowed to prevent joint stiffness and muscle atrophy. What are the various techniques of surgical management? Number one, external fixation. These are indicated in fractures with soft tissue contamination that can be open injuries, multiple fractures with poor general condition of patients with systemic involvement. So in the picture, you find there is a picture of the leg with a comminuted fracture of the tibia. We can't see the skin, so it could be compound. And now it's not easy to manage this. And you find that 2 pins above, 2 pins below are inserted into the tibia, and 2 rods are there to connect the shank screws. It is called as external fixation. There can be other option, which is open reduction and internal fixation. It is required when there is inherent instability of the fracture fragments and their distraction caused by muscle pull. Fractures which poorly unite, such as fractured neck of femur, have to be fixed internally. Then there are fractures which are involving the joint, and there are fracture lines going across the articular cartilage, articular surface. These fractures need perfect anatomical reduction, and hence they call for internal fixation. What are the various methods of internal fixation of fractures? Screws only can be an option. You apply plate over the fragments and fix the plate with screws can be other options. You can use wires to fix internally or externally the fractures. You can use solid or hollow nails which are going intramedullary to align the bone and fix them. And the wires, again, this has come twice, sorry for that. But every technique has merits and demerits, advantages and disadvantages. What can be the disadvantages of internal fixation, of surgical management, we should also know. Involves surgical opening. You have to incise the skin, you have to cut the muscles, and that increases the chances of infection. That in the process of fixation and reduction, you need at times stripping of periosteum, and that decreases the blood supply of the bone, and that delays healing. Because you know, periosteum has osteoblasts, and osteoblasts are the cell that forms new osteocytes. All the new bone formations happens either at the level of endosteum or periosteum or epiphyseal plate. So you cannot afford to damage periosteum. And if you are careless in fixing, in surgically managing the fragment, you might damage the neurovascular structures. That is a further complication. That's very bad. These are the few X-rays to demonstrate internal fixation. X-ray number 1. First X-ray showing AP view of the arm, showing humerus, shoulder joint, partially elbow joint, and there is a fracture which has been fixed by plate and screws. In the middle X-ray, you find there is a AP view of femur showing long oblique fracture of femur middle shaft that has been fixed by an intramedullary nail, and the nail has been fixed by intramedullary screws. The third X-ray extreme on the right shows a AP view of the distal end of femur, and there is a long oblique unstable fracture at the junction of middle and distal 1/3, which has been fixed by long plate and so many screws laterally. Thanks a lot. These are the basic